I'm joined this morning by Dr. Julia Jenkins. She is from Central Iowa. She is a Unity Point Physician Champion for the Documentation and Risk Score Accuracy Initiative. She's going to kick us off in just a moment by providing an overview of the project. I'm going to first cover the agenda. Where I mentioned that we'll be talking about the initiative. We will also go over risk scoring and talk a little bit about a specific type of risk scoring called ABCC. Just a reminder for those who have joined, if you could put your computers and your phones on mute unless you're asking a question, just helps with the audio quality. Thanks, everyone. We will also be going over the training and support approach for the implementation of the technical solution. As I said, giving you that demonstration, and we should have plenty of time for questions and answers following that. I'm going to turn it over to Dr. Jenkins to give us an overview of the initiative.
Good morning. Thanks for joining us this morning. For those of you who don't know me, Julia Jenkins, I'm a family medicine and hospice and palliative care physician here in Central Iowa. I also split my time. I'm 50% clinic and I have 50% here in the ACO as the medical director. So I've had a lot of exposure to the type of risk contracting and things that we are seeing from a payer side. So I'm really excited to be able to talk with you this morning about how Unity Point Clinic has really taken the lead in helping physicians improve documentation accuracy so that we can appropriately increase the risk score based on the illness burden and complexity of the patients that we're taking care of. Unity Point Clinic has really done a great job in partnering with Clinnovations to develop this solution for us. They have put quite a bit of time and effort into this over the last several months, and I've been involved in it in many different aspects. We have done a great job with putting together a group of physician champions, and those physician champions have worked together countless mornings with Clinnovations, going through step-by-step of what the solution is and how it would integrate into Epic and how it will integrate into our workflow as physicians here at Unity Point Clinic. We've done a lot of work, and I think that due diligence has been done on the part of Clinnovations and Unity Point Clinic and ensuring that this is easy to use and integrates into our workflows and helps us with making the transition that's necessary as we look the way that the healthcare market is changing right now, moving from our traditional fee-for-service where we pay physicians based on if they see a patient and how many times do they see it, more to fee-for-value is what we call. So we look at caring for populations of patients and what the illness burden of that population is. So with the jumble of electronic medical records, we've discovered that we're kind of losing the city of patients. And this is really a tool that integrates into our network to help us realize that there may be things that are very important to that patient's health that we need to integrate and account for in order for the insurance companies and payers to understand how ill or how complex a patient is. So as we sat down and realized this, and we were going to put the time and effort into creating a solution for our providers, Unity Point Clinic really went together and had a very dedicated, thoughtful approach to how they did this. There was an assessment and validation of the need to do this work. Phase one started off with just meeting with Clinnovations, understanding what their solution was, how it would be built, how to integrate it into our practice here. We have multiple different teams working on this between IT, lots of physicians. The physicians have been very involved in how this works, in addition to our great coding team and all kind of coming together to figure this out. We had quite an advanced schedule in how we would roll this out with pretty set timelines that we had to work very quickly to make sure we were getting the work done and moving forward so that we could get this implemented as quickly as we could. because it is a real benefit to our physicians and to our practice. So we are lucky here now to be in the kind of middle of this graph that you're seeing here. I think we're in week 7 right now, which is kind of the final phase of that solution build, initial practice, and deployment. Next week, we'll have our pilot clinics go live. We have 2 pilot clinics that will be testing the solution and ensuring that everything works right. And then the week after that, so the week of July 18th, Central Iowa will go live with this, and we will have the training and development that Mary's going to talk to you more about. This coincides nicely with work that Unity Point Clinic is doing on just general increased education to our providers around risk scoring. So we here in Central Iowa have on the 18th and 19th, or I'm sorry, maybe the 11th and 12th of July, scheduled those meetings with Dr. Solomon, who's a national expert in risk scoring and documentation. That's going to give us some good background basis education so that we completely have knowledge to help with the integration of clinicians and execution of this throughout our health system. So I'm really happy Mary is joining us this morning to help us understand and give you guys some background on this. And I will be here to answer any questions that I can throughout the call. Thanks, Mary.
Thank you, Dr. Jenkins, for that introduction and overview of the work so far. As Dr. Jenkins indicated, Central Iowa will go live the week after next, so starting the week of July 18th and for 2 weeks. And we'll talk a little bit more about training here in a moment, but we are getting communications out to the individual practices to let them know what days during those 2 weeks will be in the practice and how that day will look in terms of training. Understanding that we're getting close to July 18th, and as Dr. Jenkins said, just trying to implement this work very quickly, and appreciate everyone's understanding and patience with that. As Dr. Jenkins mentioned, we are moving from a more traditional fee-for-service type of reimbursement model to these value-based or risk-based contracts. And the CMS, or Centers for Medicare and Medicaid Services, are a great example of how that transition is happening. Just looking at some of these statistics on this slide, you can see that 40% of the Medicare population in the next 9 or 10 years will be covered by their Medicare Advantage program. I'm going to talk a little more about Medicare Advantage here in just a moment. In the next 2 years, 50%, half of all CMS payments will be tied to risk models, and 70% of Medicaid is currently in some form of risk contract. I mentioned Medicare Advantage is probably the best known reimbursement model for these types of risk contracts. They have a model called HCC, or Hierarchical Condition Category. I'm going to give you a little background on that model. It's the model that we have used in this technical solution that we'll be implementing in Epic. It is a model based on risk scoring. So patients are given a risk score based on a demographics factor, so age, sex, the reason for their eligibility for Medicare, and then their chronic condition profile. So what chronic conditions do they have that carry this HCC value or carry value in this system? And there are nearly 9,000 diagnoses or ICD-10 codes that have that HCC value. These are chronic conditions that are commonly found in a Medicare Advantage population. So each one of those conditions has a value. They use a mathematical model to add the values across those different chronic conditions. They come up with a risk adjustment factor. You can think of it as a risk score for each patient, and then payment is based on that risk factor. You can think of it as indicating how complicated a patient is or how complex they are to care for. Documentation is an important piece of these models. So when you are coding and billing an HCC diagnosis, you have to have proper documentation in place. indicating a status, a treatment, and a follow-up for that patient. The billing will go through and create, over the course of a calendar year, a patient's risk score. I mentioned calendar year because this is a prospective model. The chronic conditions that have value in this program that you bill in 2016 sets the reimbursement rate for that patient for 2017. I wanted to give you a clinical example to really drive the point home, what kind of difference this can make both in terms of charting accuracy and reimbursement when you're working within this type of model. So if you're seeing your patient, you know her very well. She's an older woman, 85. She has a history of diabetes. She's had complications from diabetes, but she's coming in with something acute. She has a UTI. She's also feeling fatigued. So you do an appropriate history, physical workup, and you diagnose her with a UTI, which you will treat. You are managing her diabetes. Her fatigue is related to malnutrition. You're going to have her see some specialists. So we know that you're taking good care of your patient, but documentation and billing doesn't always indicate what plan of care was in place. So if we look at the bottom, we'll look at the orange column here. So in a more traditional fee-for-service world, you're indicating that your patient has diabetes and she's coming to see you for a UTI. Under these types of chronic condition models, the UTI has no value because it's not chronic, it's an acute issue. The diabetes has value. She has a demographic factor to her risk score. And if you calculated that out annually, the reimbursement for this patient would be somewhere around $7,600. But if you documented completely, more comprehensively, and billed under this new system, you're indicating that she has complications from the diabetes in terms of nephropathy. She has peripheral vascular disease. She's had an amputation. She's malnourished. All of these things also have value under this program. And you can see that it makes a huge difference to the annual reimbursement for taking care of a patient this complex. Just to make sure, really drives the point home about why risk score accuracy matters. We've talked about accuracy in documentation, making sure the whole care team is on the same page. Everyone has a comprehensive view of the patient's health. We're recognizing and potentially closing clinical care gaps, as well as reimbursement gaps for patients. It helps facilitate proactive management of chronic conditions. You may identify and address conditions that were previously undocumented. It helps support problem list maintenance. I'll get into how that works with our technical solution here in just a few slides. And aligns Unity Point's risk-based reimbursement to the full complexity of your patient population. So I'm going to move here in just a moment to the technical solution, some highlights. I wanted to see if people had questions about risk scoring, Medicare Advantage, this model, before we move on to the technical solution. Okay, please, if you do have questions, just interrupt and let us know. So I wanted to point out some highlights before we do the demonstration in Epic. And clearly this is not Epic, it's kind of a genericized electronic health record. You'll see that there is an element in the patient's header that is called, here at Unity Point, the risk gap. It will indicate a number if this patient has chronic conditions that still need to be captured in the calendar year. So I'll show you how that works here in a minute. It's a dynamic piece of the header. You can click on it, and you'll get a dialog box coming up that shows you what those conditions are that are contributing to that gap, and it'll give you the ICD-10 code. And when I talk about gaps, what I mean is at the beginning of the year, because this is based on a calendar year, the score will be potentially at its highest if you didn't add any new conditions in that calendar year. So as you capture them, you assess, you document, you bill, that score or the gap that we're showing you is dropping, so that by the end of the year, your goal would be that gap is 0. And at that point, this part of the header, your risk gap, will fall off the header, and you won't see it for these patients who are in scope for this project. Then we have what we call the SMART form, where the documentation and the billing occurs. So again, we'll show you more details here in a moment, but the SMART form will present to you diagnosis sections like COPD that have value under this HCC model. And you'll have documentation options to quickly, with one click, indicate a status, a treatment, and a follow-up for that diagnosis. And then there's a field where you can enter the diagnosis, and that will take care of the billing. You are only seeing a SMART form if that particular condition has not been billed in the calendar year. Once it's been billed, it drops off of the SMART form. It's not presented to the provider. Problem list is critical to the functioning of this technical solution. Of course, it's critical for a number of reasons, but it's the HCC valued or risk score valued chronic conditions on the problem list that will trigger that SMART form. That's probably 80% of what will trigger the SMART form. We also do look for other clinical data in the chart, such as a patient's body mass index, if it meets criteria for morbid obesity. Even if it's not on the problem list, you will see a SMART form section for that. There's certain lab data that will trigger it, such as a GFR that would meet criteria for chronic kidney disease, stage 4 or 5. And then elements from history, such as the history of amputation, as we saw with that patient example. We are nightly updating based on billing data, as I had mentioned, to make sure that we're only presenting providers with those particular conditions that are still outstanding for the calendar year. Just wanted to take a moment to mention a little more about problem list and principles of good problem list creation and maintenance. When we are out in your offices, we will be distributing documentation that UnityPoint has put together to help support good problem list creation and maintenance. And we will be able to assist your providers with any of the technical aspects and ethics that might be helpful in creating and maintaining the problem list. But as you know, it's dynamic, and it's shifting. Change is underway. It's shifting from more of a provider-focused problem list to one that really tells a patient's story based on their significant current or historical medical issues. We all know that patients are ever more engaged in their care. They regularly access their records, whether they're looking at MyChart or their after visit summary that we hand to them on the way out of the office. So they're seeing that problem list. And so that's another reason that we want to keep it up to date. In an ambulatory setting, clinical or nursing staff may edit or add to the problem list under the direction of their provider. And as I said, at Go Live, we can support any questions about the problem list or the technical aspects of maintaining one. The patients who are in scope for this technical solution, this slide indicates what payer groups those patients come from. So as I mentioned, traditionally it's Medicare Advantage. So those patients covered by these Medicare Advantage insurers will be in scope for this project. But we're also looking at all Medicare, including the next generation ACO. All of these insurers listed here, UnityPoint Health has at-risk contracts with or expects to in the near future. So we're including United Commercial and we're including Wellmark Commercial. And we've done analysis to indicate that despite this large patient population covered by these insurers, we still think that the trigger rate for the SMART form per provider on average will be very reasonable, something around 2 to 4 SMART forms triggered per clinic day, so a very manageable number. As we are coming out to your offices during Go Live, the weeks of the 18th and the 25th in Central Iowa, next week at our 2 pilot sites, we will be working ahead with you to find a 1 or 2 time slots of 30 to 45 minutes where we can get most of the practice together to go over this same information, overview of the project, risk scoring, and show a demonstration of the solution. We'll go through the workflow, we'll have time for questions and answers, and then we'll stay in your office for that day to make sure that we can support any live smart forms that are triggered. Throughout the 8 weeks of Go Live, we'll have a helpline available that we'll publish to you so that during clinic hours you have someone to call if you have questions about the smart form.